Yes, we have attendees coming in. Thank you for your patience, everybody. Thank you for hopping in today. I'm really excited to invite you to our first collaborative webinar of the new year between Goldstein Wellness and Realm of Caring. And what a great time coming off of last year and a great topic for us to have to discuss here, especially as we learned of the potential of the rescheduling of cannabis to Schedule 3. So, in other words, acknowledging the medicinal value that cannabis has and the potential of Medicare coverage for specific cannabinoid products. And so, it's really important to continue these conversations of medicinal value and what cannabis may do or help people with for specific conditions, specific symptoms. And today, who better to talk about cannabis as a substitute for opioids than Dr. Bonni Goldstein? I'm so glad that we can present this to you, or Bonni can have this great presentation for you all. And I want to remind everybody that if you have questions, just please use that question box. We'll be moderating some in the last about 5 to 10 minutes of the hour. And I also want to remind you all to stay in touch with both Goldstein Wellness and Realm of Caring. There's lots of opportunities to get, whether you're a provider or patient, get your patients discounts through the Goldstein Wellness Marketplace, but then also to get involved in research. There's compensation for your patients if you are a provider in that regard. So just reach out and ask us questions. And without further ado, Bonni, I won't take any more time. I will
Oh,
let you go ahead and start with this great presentation today.
thank you. Oh, I just lost a headphone. Can you hear me
Okay.
okay?
I can, yes.
Okay, great. So welcome everybody. And Happy New Year to everyone. I agree this is a great topic to start with. This is a big problem with the opioid crisis that we have, and we've got a lot of things to cover here. And I just want to say welcome to everybody, and thank you to Realm of Caring for co-sponsoring with us and for being such a great partner. If you're not familiar with Realm of Caring, of course, they're a longstanding nonprofit, helps patients through education and research. I love collaborating with them. And so let's get started. All right. So if you're not familiar with me, I trained as a pediatrician. I've been a doctor for a very long time, too many years to even talk about. I trained at Children's. I worked in critical care transport and pediatric emergency medicine for a number of years, a little over a decade. And my eyes were opened to cannabis by a friend of mine who was struggling with side effects of chemotherapy. And um, she asked me about cannabis. I didn't know very much. I delved in and haven't really looked back. I own a practice and I own Goldstein Wellness, which is a website to help educate everybody, including healthcare practitioners, on medical cannabis. I've written a book, as you can see, and then I have some consulting work and some memberships that I'm part of, some professional societies. But let's get started on the topic. So we have a lot to cover. We're going to talk about definition and impact of chronic pain, the biology of chronic pain, the opioid system, as well as the endocannabinoid system and the interaction between these systems. Then we'll take a look into the real world studies looking at opioid sparing effects of cannabinoids, meaning how do cannabinoids help people, or do they help people get off of opioids? And also why anybody might choose cannabis over opioids. And then also we'll just briefly touch on OUD as opioid use disorder and how cannabinoids may help there. We'll talk about the public health considerations, and then we'll talk about opioid tapering and cannabis integration. And so what is chronic pain? So chronic pain is pain that is defined as lasting equal to or greater than 3 months. In the United States, between 2019 and 2021, the prevalence of chronic pain was somewhere between 20 and 22%. And the prevalence of what's called high impact chronic pain, that's pain that is resulting in substantial restriction of daily activities. You can't go to work, you can't climb the stairs in your house, you are struggling to have any function. And that's pretty high, somewhere between 7 to 8%. And what do these numbers equate to? So 51 million US adults are currently struggling with chronic pain, and 17 million have high impact chronic pain. And this, according to the US Institute of Medicine, the economic cost of chronic pain to our society ranges between 500 and 600 billion dollars annually. We all know about the opioid crisis. In 2020, we had almost 69,000 deaths. In 2021, it was significantly worse, 80,000 plus. And the cost to our society is over $500 billion annually in a total economic burden. And I just want to point out, of course, we have been severely restricted from studying cannabis because it's a Schedule One, and as Sasha mentioned, that's going to change hopefully soon. And we've been allowed to study it for its detrimental effects, but not so much for its positive effects. But here and there, we do have some studies, and that again, remember, that's just here in the United States. There are studies from other countries where they have allowed research. But we're going to take a quick look at the different kinds of pain, and then we'll review the research, okay? So there are different kinds of pain. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And this definition was changed a little bit to acknowledge that pain can occur in the absence of identifiable tissue damage, like things like fibromyalgia or migraine headaches. Some of the latest reports describe these types of pain. So we'll just go through real quick. Nociceptive, you see on the bottom left in the purpley blue color there. This nociceptive is a type of pain that's like chronic back pain, osteoarthritis, gout, bursitis. Neuropathic pain means that it stems from a problem with the nervous system. Neuropathic is nerve-derived pain, and that includes sciatica, radiculopathy, post-stroke pain, spinal cord injury, multiple sclerosis, trigeminal neuralgia, anything really from where there is a nerve involvement. And it's notoriously difficult to treat, and opioids are often prescribed, but they often don't work very well. We often see drugs like gabapentin and drugs brand name Lyrica or pregabalin that get prescribed. In fact, those are two very popular medications for neuropathic pain. And some people say it helps and some people say it doesn't. And then there's also nociplastic pain, and that's the abnormal processing of pain signaling without any clear evidence of tissue damage, going back to what I've mentioned, fibromyalgia, irritable bowel syndrome, chronic fatigue, chronic headaches, or migraines. And then, of course, there's mixed pain, and this is a crossover. So mixed pain could be that you have low back pain, which then slowly turns into now back pain and sciatica, or having cancer pain, like a tumor, which is causing tissue damage and inflammation, but it's also compressing a nerve. So that would be what we call mixed pain. Now, this slide shows you the pain pathways, and really it's fairly simple. And if you look at the slide, you see there's this noxious stimuli right here on the hand that looks like a nail or something going into the hand. We have these little receptors called nociceptors. They detect the threat or the pain, and that starts this ascending pathway up to the brain. So it goes through the spinal cord, up into the brain. And this system, this ascending pain pathway, tells the brain that pain is happening and how intense it is. But we also have what's called the descending. You can see here in the green. The descending pathway is the brain's built-in pain control system. These signals are basically sending a message down to dampen down the pain. So the way to think about it is ascending pain going up turns the volume up. The descending system coming down turns the volume down on pain. In many chronic pain conditions, be aware that the issue isn't just always too much pain heading up to the brain. It's often there's a loss of control or pain control in that descending pathway. There's also many other reasons why chronic pain happens, and I'm not going to spend too much time on this, but remember, it's not just an ongoing tissue injury or abnormal pain signaling. It's the whole nervous system going to be involved in the problem. So there's what we call amplifiers. So we have these compounds or chemicals in our brain, glutamate, substance P, and some others that kind of are amplifiers, just like you could use an amp for a guitar to dial it up. It's the same thing. It dials up the pain. And ongoing neuroinflammation. There's also cells called microglia that get activated, and these are what they call sustainers. They keep kind of that pain messaging ongoing. And if you don't address it, of course, that's why the pain continues. Also, peripheral nerves can become hypersensitive. Of course, there's genetic and epigenetic vulnerability. There's also psychological and stress factors that further fuel this cycle. It becomes this vicious cycle. And then, of course, the endocannabinoid system, which is involved highly in regulating pain, which we're going to talk about. If you have a dysfunction in your endocannabinoid system, that also continues this vicious cycle. And then, of course, opioid-induced hyperalgesia. So in some cases, people get put on opioids, and in some cases, that can actually dial up the pain messages. It's not always doing what we're asking it to do. Now, let's quickly talk about the opioid system and how it modulates pain. So all of us produce inner opioids. You've probably heard the term endorphins, but there's others. They're called enkephalins, dynorphins, and endomorphins. And these are compounds that bind to our opioid receptors and reduce how we perceive pain. It's really a perception issue. And it's a normal protective system. It's one of our inner pain control systems. Prescription opioids act on these same receptors. Remember that, right? And so when they bind, it's a little bit stronger and they can produce pretty powerful pain relief. And that happens because the opioids inhibit the pain signaling in the brain and in the spinal cord and just kind of quiet down and turn down the pain messaging. And of course, from a clinical perspective, many of these receptors are involved, but one of the main ones is this one, MOR, you can see here in the yellow. That's the mu opioid receptor. That is the one that plays the biggest role in analgesia, but also remember that it's tied to reward, tolerance, and dependence and addiction. And this is where the challenge comes in, is that with ongoing opioid exposure, so for instance, you're taking opioid pain medication, the system will adapt, and over time, the body will produce fewer of its own inner opioids. The receptors become less responsive. And then what happens is you need an escalating dose of your opioids. And then, of course, that's where we get into trouble, risk of side effects, dependence, misuse, and even overdose. I'm not anti-opioid. I think opioids are very important. They're very effective in the short term, usually for acute pain, but long term, they cause issues. And I will share with you that in my experience meeting with patients that are on opioids, I know I see a skewed population. They're coming to me to see if they can use cannabis instead, but they all report just feeling terrible on long-term opioids, brain fog, constipation, irritability, sedation, escalating use, fear of misuse or being addicted. All of these are playing a role in why people might seek out other pain relieving substances. And so just the same way we have an opioid system, we also have an endocannabinoid system, and it is made up of different parts. Endocannabinoids are inner cannabis-like compounds. We have receptors, type 1 and type 2 receptors, and we also have enzymes. It's a pretty extensive system. I'm not going to spend too much time on that. And I did do a talk with Realm of Caring, which should be available on their website, that you should be able to see if you want to deep dive into the endocannabinoid system. But we have these two receptors that are involved in pain signaling. So the type 1 modulates pain signaling in the brain and the spinal cord, and the type 2 receptors are found mainly in the immune system and peripheral tissues. And when they're activated by our inner cannabis-like compounds or by cannabis compounds from the plant, they help reduce inflammation and immune-related pain. And remember, inflammation is a key contributor to many pain conditions. And if we can get the inflammation down, we can often get control of the pain. Now, importantly, it's important to understand the endocannabinoid system doesn't just block pain signals. It helps fine-tune pain regulation. And there's evidence that it strengthens the brain's descending control pathway. And as you can see on this graphic, you can see all of these different cannabinoid receptors at various places in the ascending and descending pathways. And so remember that when our endocannabinoid system, by the way, is all over our bodies and in our brain, cannabinoids can influence pain through multiple mechanisms. So in the brain, in the spinal cord, at the level of the peripheral nerves in your hands and feet and so on, and also improve that pain inhibition, that descending message of turn down the pain. And it doesn't rely on a single pathway. Now, the endocannabinoid system and the opioid system overlap. And as you can see, this is a funny looking, does not look like a brain, but that's the brain. And what it shows you here, if you just look at the legend, is the type 1 cannabinoid receptor. You can see it's highly dense in the darker areas, the darker blue, and then the medium blue is moderate, and then the cannabinoid receptors have low levels in the areas that are light blue. And then for the mu opioid receptor, you can see 3 stars means that they're dense in that area of the brain, and so on. You can see, kind of shifts down the same way. Be aware that this overlap is very important because both of these systems regulate pain, stress, anxiety, and reward. Also, there are some studies in animals that show that actually taking THC triggers the release of your endogenous opioids. And that may be one of the mechanisms by which THC can help combat pain. And of course, one important difference, a very important difference, is opioid receptors are abundant in the respiratory control center of your brain. CB1 receptors are basically sparse in these regions. And this is why opioids can suppress breathing and cause a fatal overdose, whereas cannabinoids do not produce a lethal respiratory depression, even at high doses. And again, this is why we're talking about cannabinoids to help to control pain with or without in combination with opioids. One other thing to share is the endocannabinoid system changes with chronic pain and neuropathy. There are changes. It's a dynamic system. And so chronic pain and neuropathy can alter the receptor activity, can also alter endocannabinoid levels. And also it's been shown that these alterations, because remember, your endocannabinoid system isn't just dealing with pain, it's dealing with your emotional being. So these changes not only affect pain, but can contribute to the emotional component of pain. And the idea is if you're going to use cannabinoids, that you are restoring or enhancing the endocannabinoid system to rebalance your pain regulation and, of course, kind of rescue that emotional difficulty that might be happening from these changes in the endocannabinoid system. So what does the research show in terms of evidence for cannabinoid and opioid synergy? Meaning used together, what do we see if we're taking advantage of both systems that help regulate pain? So in preclinical studies, this means animal studies, the findings are fairly consistent. When THC is added to morphine, the amount of morphine needed to achieve pain relief is reduced by about 3.5-fold, more or less. And also be aware that the studies in animals, there was no evidence of increased opioid abuse risk when cannabinoids were added in. This is a concern. If we add cannabinoids, now are people going to just be abusing both? And will that even escalate use of opioids to cause an overdose or create addiction? And that was not shown in the preclinical studies. Then there's a group of studies that look at experimental pain in healthy volunteers. So healthy volunteers are recruited, and for instance, they can get a little shot in their arm of capsaicin, which causes a burning sensation, and then they're given cannabinoids and opioids, and they're studied. So really, these studies showed mixed pain effects. Some showed more pain, some showed less pain. And I do want to say there's a major limitation with studying cannabinoids and opioids in healthy volunteers. And remember, it's because there are underlying changes to your physiology when you are experiencing chronic pain. And that is not the same as someone who is a healthy volunteer. So it's very hard to compare. It's a little apples and oranges. But again, sometimes that's the way that we've been able to get studies done. Now, what about randomized controlled trials in humans? So in acute pain, the randomized trials have not demonstrated an opioid-sparing effect when cannabinoids are added. In cancer pain, same thing. There was no reduction in opioid doses or pain scores, and there were actually more adverse events with cannabinoids. And then in chronic non-cancer pain, Mostly, they did not show evidence of synergy for pain relief. And dronabinol, which is a synthetic THC, Marinol, which is often prescribed, that also didn't show any benefits. So before we say, well, then what the heck are you going to talk about the rest of this? If it doesn't work, it doesn't work. Be aware that these studies absolutely do not reflect real world experiences of patients using either combination cannabinoid or opioids or using cannabis to get off opioids. Most trials use synthetic THC or isolates, not the whole plant cannabinoid based botanical formulations that medical cannabis patients are using. Also, remember in studies, often they use a fixed dose. So they pick a dose and that's what you get. And we know with medical cannabis and with cannabinoid medicine, you must customize, right? We know there are patients who can't tolerate more than 10 milligrams of CBD and other people need 500 milligrams. So in a study, it's a fixed dose and doesn't allow for that customization, and also short exposure periods. So there's one study I'm going to show you that only gave CBD for 3 days. And so again, the expectation is one, and I've seen many studies where they just give one dose of CBD to see what's going to happen. And frankly, that's not really going to work in my opinion. And remember, as I've mentioned, experimental pain models do not equal what's happening in a person who's experienced chronic pain. So we do have an issue with the data, and we can do better. And hopefully the rescheduling will allow us to get some research done. But the real world data is going to show you what people are finding. And we have to start recognizing that this is evidence. The world we live in now, what a person reports outside of a study is never really considered evidence. But it's very hard to measure pain objectively, so we have to go by what people say. And before we get to that, I just want to explain there's two different types of ways that we may look at cannabis for opioids. So cannabis treatment used to reduce the use of prescribed opioids in someone who's a chronic pain patient who's getting prescribed opioids, but they do not have an opioid use disorder. And then there's also what do the studies show when you introduce cannabinoids to people who are struggling with an opioid use disorder? Does it help them get through that disorder and become free of that? And so we're going to go through all of that. 9 years ago, the National Academies of Sciences, Engineering, and Medicine published a report called The Health Effects of Cannabis and Cannabinoids. You may have seen this. 16 experts, over 10,000 studies. They concluded that we found substantial evidence that some cannabis products are effective for the treatment of chronic pain patients or chronic pain in adults. And I just want to say that many people still don't know about this. I read a study once that said it takes 17 years for anything in the literature to really get down to the clinician. Very long time. But this is clear cut because they did not find substantial evidence for other things. And of course, a lot of it's based on the fact that the studies have been limited. But for this, there's substantial evidence despite the studies being limited. And if you look, they included 28 trials. They had combination CBD THC, some smoked or vape flower, some oral synthetic THC, and 3 that used a THC spray. So we have these handful of studies and the substantial evidence, kind of the stamp of, it does work. And so when people say, oh, it doesn't really work for chronic pain, that's not really what the research shows. Okay, let's go on. So this is one of the first studies looking at this topic. It was published in 2011. This was out of UCSF, where they recruited 21 adult patients with chronic pain. They were actually asked to stay in the hospital for 5 days so that everything could be controlled, all the variables could be controlled. These were people who were on twice daily sustained release morphine or oxycodone, and they were given vaporized cannabis, and they continued their regular opioid dose without any changes. And what they found first was that pain decreased by an average of 27%. And there was no change in the opioid blood levels. So they followed the levels of opioids over those 5 days before and after as well. And they didn't see any change in opioid blood levels. So the reason they did this study was to see, does cannabis block the metabolism of opioids. So those build up in your bloodstream, and that's why your pain is better. And that is not what happened. So there was improvement without altering the opioid pharmacokinetics. And this supports the concept that the combining the cannabinoids with opioids allows for more effective pain control and taking advantage of both not just the opioid system, but also the endocannabinoid system. This is a prospective cohort study called the effective of medicinal cannabis on pain and quality of life outcomes in chronic pain. This was at 274 patients that were approved to use medical cannabis in Israel through their Ministry of Health. 176 patients completed the follow-up, and they were given options: inhaled, edibles, or oil. And people often ask, well, what were those made up of? And I was so pleased because the study publishes. It was THC content was between 6 and 19%, and the CBD content was between 0.2 and 5.5%. So there was a little bit of CBD in there. Over the study period, patients improved across all pain outcomes. So pain symptoms significantly improved, pain severity went down, and pain interference, meaning interfering with your ability to function, that also decreased. And improvements in social and emotional disability scores were noted. 44% reduction in opioid use, and only 2 patients had serious side effects. 1 patient had elevated LFTs, which is liver function tests. We do see that. It's usually when there is another medication on board that's also affecting the liver. This is completely reversible by removing the offending drug or removing cannabis. And then 1 elderly patient got confused, and I suspect they may have had taken too much because they ended up in the hospital and they were kind of watched very closely for a few days, but that resolved issues. But in general, most of these studies, as you will see, they were very well tolerated. Cannabinoids were very well tolerated. Now, this is a study that looked at over 240 patients in Michigan. So these were approved medical cannabis patients in Michigan who were struggling with chronic pain and were using medical cannabis. And they were asked to report on their opioid use, their medication side effects, their quality of life. And what they saw there was 64% reported a reduction in opioid use after starting medical cannabis. 45% reported improved quality of life. And then there were fewer overall medications used by the patients and fewer medication side effects. That makes sense, right? And so these findings suggest that patients are not simply adding on, but also they're able to lower those opioid doses. And some people are able to discontinue, as you'll see. Now, this was a pretty large study. This was nearly 3,000 medical cannabis patients. About a third had reported using opioids in the prior 6 months. And among those using opioids, 97% reported decreased opioid use after starting medical cannabis. 59% reported complete cessation of opioids. What great results, right? Most common reasons for substitution: less side effects, better symptom control, and improved quality of life. One of the, I think, wonderful things about cannabis is that it's very flexible. I can take a little bit more when I need it. I can lower it down when I don't need it. I can try different products. With opioids, of course, you can cut the pill in half, or you could take a little bit less. But it just seems to me that we have so much flexibility with cannabis that you can dial it in. And one of the things that I've absolutely seen in my practice with patients who have chronic pain, when they come in, it's, they don't feel in control, whether they're on opioids or other pain medications. I noticed this very early on when I first started working in this field, is that cannabis switches the control from the disease controlling you to you controlling the disease. And that is huge for people, especially people who feel that their medical condition, their chronic pain is, for lack of a better way to say it, ruining their life. You get that control back and you're able to manage your symptoms without being afraid of the side effects and the risks. Now, this is an interesting study. This one came out in 2019, and this one looks at the effects of CBD hemp extract on opioid use and quality of life in chronic pain patients. Excuse me, I'm just going to take a sip. So this was 97 patients. They were on opioids for at least 2 years. So these were patients who were relying on opioids. 8-week study, so pretty short, but gives you 2 months to figure it out. They were evaluated at baseline, 4 and 8 weeks, and there were 4 different assessments looking at pain, overall quality of life, sleep quality, and also another one for pain, but also that measures pain interference. Is it interfering with your life? 53% reduced or eliminated opioids, and 94% reported quality of life improvements. Significant relationship between CBD and sleep, and also CBD and pain intensity. And remember too, that so far studies have not really shown that CBD immediately helps with sleep or puts you to sleep the way THC or CBN might. The idea here is that CBD is very likely alleviating inflammation, pain, and often anxiety, which then allows you to sleep better. Okay. And so they did see some added benefits here with sleep and also pain intensity. So it's very nice to see these reports. And additionally, I forgot to put on the slide, some of the patients involved in this study were also able to reduce their anxiety medications and their sleep medications. So remember, it's not just opioids that patients can get off of. This is a very large study, over 2,000 patients. And this was out of Florida. So this was after Florida passed their medical cannabis laws. They evaluated patients between the ages of 20 and 70. And 61% of the respondents, so a total of 1,331 patients, reported using opioids. And in this population, 79% reported reduction or cessation. I mean, we're kind of going through, you're seeing 40%, 59%, 60 plus percent, 70%. These are really interesting numbers, right? It's even if we know this is subjective, it's very hard to measure pain. And this is why placebo studies are important, so you can really see what the effect is. But at the same time, remember, all of these people are buying cannabis out of their, out of pocket. It's costing them, and if they're getting relief, they're going to stick with it, right? Most patients in this population who got relief rated medical cannabis as very or extremely important to their quality of life. Additionally, the researchers reported self-rated changes in functioning, and there were improved domains of bodily pain, physical functioning, and social functioning. And this is a quote taken right from the article. Initiation of medical cannabis laws could lead to public health changes through the potential opioid-sparing effects of medical cannabis without worsening health functioning. And I think that's really important. We have to stop ignoring surveys like this. Everyone says, well, it's not real science. We're seeing the same thing kind of over and over. It is compelling information, compelling findings. Now, this comes from our friend, Dr. Dustin Sulak, and our friend, Dr. Kevin Takakua. What they did was they went to 3 cannabis clinicians and said, we want to do a survey. And it was 525 patients. And the criteria to participate was you had to be on prescription opioid medications continuously for at least 3 months, and then in combination with medical cannabis then added on. And so after initiation of medical cannabis, 40% stopped all opioids and 45% reduced opioids. Those are, good numbers, right? 87% reported improved quality of life. 80% noted improved ability to function. 48% reported somewhere between a 40 and 100% reduction in pain. 65% sustained their opioid use changes, meaning if they lowered their opioid dose or got off their opioids, that was sustained for more than a year. So it's not like they used their cannabis, answered the questions, and then went back on their opioids. This was sustained decrease or discontinuation of opioids. And then 63%, when asked, reported they did not want to take opioids in the future. Now, what about for specific conditions? So this is a very nice study on individuals with fibromyalgia. And I'll just give you a little background. So this was an online survey. There were 878 people that participated. They lived in 48 states. So there's no representation from Wyoming and Vermont, but every other state was represented. There were 5% of these respondents were Canadian, and a little less than 2% were from English-speaking countries in Europe. And so 72% reported substituting CBD for prescription pain meds. And if you were a person who was substituting CBD for your prescription pain meds, 70 to 94% in that population resulted not just the add-on, but you were able to reduce or discontinue your medication. Now, they just didn't look at opioids here, but it was a 53% reduction in opioids. 53% reduction in opioids. That was the most common when you looked at all the different pain meds. 59% said they were able to reduce or discontinue NSAIDs. Those are nonsteroidal anti-inflammatories like ibuprofen. 35% were able to reduce or discontinue gabapentinoids, and then 23% were able to reduce or discontinue benzodiazepines like, Ativan, Valium, those kind of drugs. Interesting, of course, primary reasons. Why did you substitute? Fewer side effects and improved symptom control. And we keep hearing that over and over. Patients who substituted CBD also reported greater improvements in pain, sleep, anxiety, and overall health. And this is really very timely. CBD products that had THC in them were associated with higher substitution rates and greater symptom improvement compared to CBD isolate or broad spectrum. Broad spectrum refers to a cannabinoid formulation that has all of the compounds except THC. And so here we have yet another study that shows even a tiny little amount of THC in there can make a difference and improve results without making patients intoxicated or impaired. Now, what about the use of cannabis on opioid use disorder? So there are a number of studies. And so this is a 2020 study from Johns Hopkins, and they had 198 adults who had opioid use disorder history. Of those, 125 or 63% used cannabis to manage opioid withdrawal. 72% reported cannabis improved the symptoms of weaning off, that came from weaning off opioids. 6% said it actually worsened symptoms. 20% said it helped with some symptoms and worsened others, and 2% reported no effects. And importantly, the symptoms that were most improved were the anxiety that came with opioid withdrawal, the tremors, and the trouble sleeping. Those were the top three that were most improved, and I would say that makes a difference. And then the symptoms that were somewhat worsened, this was, you could see, not major symptoms, but yawning, watery eyes, and running nose. These are fairly common in people who are withdrawing from opioids. And so to me, these are somewhat acceptable if someone has, watery eyes or runny nose. That got a little bit worse, but I would say as a clinician, of course, let me see if we can mitigate that by switching things up, right? Not just THC, CBD, but are there other cannabinoids that might help you minimize? And we haven't gotten there yet with the research. I have not seen any research on using other cannabinoids other than THC or CBD for opioid withdrawal. We have a lot of work to do, people, a lot of catching up. All right, this one too, this was a cannabidiol for the reduction of cue-induced craving and anxiety in drug-abstinent individuals with heroin use disorder. This was a double-blind randomized placebo-controlled trial, so they had 42 individuals that had heroin use disorder, but when they were recruited and in the study, they were abstinent off of heroin. This is one of those studies where they gave just, a couple days of dosing, 3 days of dosing. They got 1 dose a day of CBD 400 or 800. And then what happens is they were, and by the way, this was purified CBD. This was not whole plant. It was isolate. They were shown neutral cues and drug cues. So neutral cues might be a picture of a car or a picture of an apple. And then when they are shown drug cues, so they're shown heroin related photos, like a needle or a spoon or a tourniquet or other paraphernalia. Um, and they were assessed at 3 different times. So they were assessed right within that first day, 1 hour, 2 hour, and 24 hours after they got their CBD dose. Short term, it was after 3 days, and then longer term or protracted 7 days after. And they went through these cues to see what's the craving and what's your anxiety levels. And what they found was that CBD significantly reduced drug cue induced craving and anxiety. They also measured heart rate and salivary cortisol, and those also went down with CBD use. And remember, too, there was a placebo in here. No impact on cognition and no serious adverse events. So the authors concluded that CBD may be a safe, well tolerated adjunct to reduce cue-induced relapse risk, because that's the idea here, is that you're abstinent, but is something going to trigger your use to get you started again? And so it looks like CBD it's certainly safe, and it may help people stay abstinent and not fall back into use. Um, this was interesting too. High intensity cannabis use is associated with retention in opioid agonist treatment. This was a longitudinal analysis. So they actually followed 2 community recruited cohorts, which made up, when you added it together, 820 people who had initiated opioid agonist treatment. What that is it means that they're on either methadone or Suboxone, the drugs that substitute. So they're in a treatment program. They followed these people over 17 years. I'm sorry, over a 17-year span, but the patients were followed for 6 to 7 years. The median was 6 to 7 years, which is pretty interesting. Daily cannabis use was significantly associated with better retention in opioid agonist therapy. So people who use cannabis at least daily had 20% higher likelihood of staying in treatment compared to non-users. And the idea here too, so think about that, is that if you're managing your sleep and your anxiety and pain, your other things that you're dealing with, you're less likely to fall back onto the opioids that are dangerous. Interestingly, less than daily use showed no benefit. Now, they call it high intensity cannabis. I have lots of patients who use cannabis daily. I don't call it high intensity. It's a medical use of their cannabis. So I'm not crazy about the title, but that's okay. Now, let's talk about public health considerations. So this has been looked at. So state medical cannabis laws, do they change what we're seeing with opioid prescriptions and health utilization? So this article, they looked at Medicare Part D data from 2013 to 2017 on opioid prescribing, specifically by orthopedic surgeons, and states that had medical cannabis laws, 20% reduction per year in opioid prescribing, and that was equivalent to about 144,000 fewer daily doses. And it's not that the orthopedic surgeons are saying, do you want a prescription or not? What we're seeing is that very likely patients are using medical cannabis, and when they see their orthopedic surgeon, they say, yeah, no, I don't need the prescription, or, you can give it to me, and then that prescription lasts 5 months, right, instead of less than 1 month. Also, the fact of dispensaries, so dispensary-based medical cannabis laws, meaning the laws that are passed in states allow for the regulation and availability of dispensaries. That was also linked to a reduction in opioid prescriptions, about 13% reduction. Remember, here in California, when the first law passed, we called it the Wild West. There was no regulation of dispensaries. It could be there one day and not be there the next day. And of course, that is not a great way to manage pain or really any other medical condition. The largest reduction was observed with hydrocodone prescribing, around 72,000 fewer daily doses per year. And what's interesting is that there was no significant reduction associated with adult use cannabis legislation. Although you'll see in another study there may be a trend. Assess trends. This study looked at. This was in Canada. So in October 2018, adult use cannabis became legal in Canada, and so of course access increased, the stigma goes down, and those patients who were saying, "I don't want to break the law," they were, of course, could now participate without having any philosophical issues. So this study assessed the trends in opioid prescribing and expenditures. So they looked at before January 2016, before the adult use laws, and then they looked after the adult use laws. And what they found, MED is the morphine equivalent dose per claim declined significantly in the public drug plans. Remember, the socialized medicine there. That was highly statistically significant. And the rate of decline was 5.4 times greater after legalization. And it was something like 20 some odd milligrams, and it came down to like 4. Total monthly opioid expenditures decreased from 267,000, this is Canadian dollars, down to 95,000. And private drug plans also had a reduction, and it was actually larger in absolute terms in opioid use. And then they also saw a decrease in 2 medications that are used often for neuropathic pain, gabapentin and pregabalin, which is Lyrica, if you're not familiar. The use of those drugs also declined. And then this one is a fairly brand new study, published October 25, so just a few months ago. And this was a large national study of over 3 million commercially insured cancer patients. And what they did was they used these databases that are de-identified, so the patient's name and other details are eliminated. And they looked at the database from January 1st, 2007 to the end of 2020. They looked at anybody between the ages of 18 and 64 with a cancer diagnosis. And they looked at age, race, ethnicity, and so on. And this is what they found. Opening of medical cannabis dispensaries was associated with fewer cancer patients receiving opioid prescriptions, shorter opioid prescription duration, and fewer opioid prescriptions per patient. Adult use dispensaries were linked to opioid reductions, even though the effects were smaller. So that's what I was alluding to earlier, is that in this study, just having cannabis legalized for adults without medical approval did also show some opioid reductions. And then the findings were consistent across all the parameters that they looked at. And so clearly, these results suggest that cannabis can substitute for opioids in managing cancer-related pain. All right, so we're winding down here, and hopefully we'll have time for questions. Last few slides. So opioid tapering and how to integrate, cannabis into someone's regimen. And I look at cannabis as, 2 ways here. So the first way here is cannabis is an adjunct. And usually this would be in patients who are need better pain control. They're on pain medicines, opioids, and maybe others, but they are not getting good pain control, and they're not functioning well. And they don't necessarily want to stop or change their opioid dose, but they would like to have better relief. And so the people who might benefit are those people who have a partial opioid response. It's often mixed or neuropathic pain, because those are difficult to treat. Often people who have escalating doses of their opioids, somebody may mention to them, you're starting to go up on this. Maybe we should add something else like cannabis. And also for those patients who have intolerable side effects from opioids. That might be who this could be added on to. And I put in the word yet there, because oftentimes when somebody does start to feel better, they are able to go down, as I've shown you in many studies. People are able to reduce, even if that's not their intention when they start using cannabis. Of course, you want to introduce cannabinoids before you taper. I get this question all the time. Should we wean off this drug before starting? And I don't want to leave a patient with a gap in control over their pain. So we would introduce, and this is how I practice, and many of my colleagues do the same thing. You introduce cannabis first, and then you don't have to taper, but first let's see, is this helping with your pain? Is this improving sleep? Is this reducing anxiety? And those are the symptoms that you're trying to help when you're adding in cannabis as an adjunct on top of your opioid dosing. And really, the goal here, you want to stabilize the patient and you want to reduce any resistance to potential taper, even if it's down the line. I've had patients that have come to me on opioids and they didn't start really weaning their opioids until 4 or 5 years being a cannabis patient. They stayed on the same dose, they got their prescriptions, and I think part of that just comes from fear of getting having the pain get worse because they remember what it was like when the pain may not have been as well controlled. So the second way I look at this is cannabis as a bridge. So this is actually where people who say, I need to get off my opioids, I want to get off my opioids, tell me how to do that. So this is support during a planned opioid dose reduction. Not everybody wants to wean. I've had patients come in and say, nope, I'm not going off my opioids. They're happy with them. They are likely people who are not experiencing a lot of side effects. And, we're all different. And so some people do not want to stop. But in this particular scenario, these are people who want to wean. They may have opioid-induced hyperalgesia, which means they're actually the opioids are making their pain worse. And also, again, as I've mentioned, the fear of withdrawal or a pain flare. That is not something fun to face when you want to go off your opioids. So again, you would introduce cannabinoids before tapering. Now, when people taper opioids in general, and this is available on and of course, I would say you want to talk with your clinician, make sure you have a plan and that you're not doing it too fast. But you can taper 5 to 10% every 2 to 4 weeks. And again, please don't do this on your own. It's always helpful to have somebody who can help you do this, some medical guidance. But again, this is going to help with pain flares. It's going to help maintain sleep, mood dysregulation, and the autonomic symptoms. These autonomic symptoms refer to diarrhea, vomiting, sweating, fast heart rate, basically opioid withdrawal, right? Which is very miserable. And so the key here is that we are trying to reduce the physiologic and the psychological stress during an opioid taper and help somebody, they're using cannabis as a bridge. And then the question becomes is once you're off opioids, are you going to continue cannabis? Do you need it? Did your pain resolve? Did something else help? So, one of the things I always say is every case is different. Every patient is unique. Not every patient with chronic pain is the same. And I think spending time, talking with patients to get those details, that's very important. And so I hope those of you who are clinicians are spending time getting that data. And those of you who are here as patients, make sure you find somebody who can help you and is listening to you because it matters. Your individual situation matters. Okay, what to expect. So as we are adding cannabinoids in, one of the first things, or a few of the first things you can expect is sleep, mood, and function often improve first. I've had patients come in who are irritable on their opioids, and a week later they'll call and say, I slept every night this past week. My mood is so much better. I feel like I can function better. That's often what we see first as we start low and then titrate up. Pain may be improving a little bit later. You have to find your dose, right? And sometimes in the beginning, the dose is too low. It might be enough to help with sleep, but it may not be enough to help with pain. Temporary pain flares or autonomic symptoms can occur, and that's okay because often what I will do with my patients, and I know other clinicians do this, is we give you instructions on how to treat breakthroughs. And that is a tool to be used when you need it. And then also you're going to reassess after the opioid taper. So if somebody's weaned down, and I don't say just after opioids are tapered off to reassess, you want to do it as the patient is weaning down to see if maybe a patient can get away with just one dose of opioids a day that makes them feel significantly better. Why do they have to go off? There's no judgment here. This is about, helping the patient find the safest, most effective treatment protocol. Once somebody, though, may be off opioids, it's very important to reassess because you may need to adjust the cannabinoid dosing and regimen, because if the opioids are removed, there may not be that synergy. And maybe we can find synergy with something else, right? And then, of course, ongoing monitoring, as I've mentioned. Just a few ideas here. This little chart that I made needs to be updated, so I apologize. We need to add CBGA here, but just the idea here is there's many different medication options under the cannabinoid umbrella. Dominant CBD, equal amounts of CBD, THC, dominant THC, CBG, the raw cannabinoids like CBDA, and other minor cannabinoids like CBN or CBDV. Just so many options. I like tinctures when I'm starting somebody out on this journey, because it allows for customized dosing. You can take 1 milligram, or you can take 2.5 milligrams if you have the proper formulation. So it really allows, especially for people who are nervous or who are sensitive, to really dial in. Often patients will be told, or patients figure out, that inhalation works great for breakthrough pain. So I have patients that they do the same procedures. If they feel an aura of their seizure coming on, they can inhale and the seizure won't happen. Same here, because if you're taking something by mouth and the pain is flaring, you have to wait an hour for it to kick in. That's where we lose benefits. So inhalation, which is more immediate, but also something that some other colleagues have talked about and that I have found is that when you inhale, you can reach a much higher peak of the cannabinoids in your bloodstream, and sometimes that is what is needed to dial down the pain. So remember, inhalation can be really crucial to helping to control breakthrough pain. And then I often recommend combinations, CBD and CBG, or CBDA and CBD. There's synergy there, and also you can sometimes get away with lower doses because of that entourage effect, that synergy. And I often see fewer side effects when patients are taking lower doses of combined cannabinoids. And then I just want to say thank you so much. And I put the Realm of Caring on here. I'm so sorry. The Realm of Caring logo somehow isn't there. I'm so sorry, Sasha. But anyway, the goal here, of course, is that, especially with opioids, medical guidance is strongly recommended. You want to make sure you're educated, make sure you're not going in blind. We want you to have safe, effective results, minimize side effects, and really kind of get the same results as some of those studies that I showed you. And then I'm just going to post the last slide. These are some of the upcoming webinars that we have in collaboration with Realm of Caring. I'm so excited to do all of these. We have the one in February is an evidence-based cannabis medicine for women. So we're going to talk about endometriosis and so on. And Ricky Lake and Abby Epstein, who produced a number of movies, documentaries on women's health, focused on women's health, are going to be joining us. We also have cancer care coming up in March, dementia topic in April, anxiety in May, and then talking more about the minor cannabinoids, the current evidence, and how patients are using these in June. So very excited to be looking forward to these.